So, Aniket, is that how I say your name?
Yes, that's right, George.
Okay, thanks. So I'm sure that Shabir has explained the procedure to you, but for those people that are first-time attendees or just wanted to be reminded, this is a thesis proposal. So Aniket is going to give a 20-minute presentation, which he will go through without interruptions, after which we will have open questions from all attendees. And is there someone here who's designated as a reader or examiner? I'm not hearing an answer, so I'm assuming no. So then we'll just have anyone who has a question can ask a question. Maybe if there are a lot of questions, we can use the chat. Maybe, actually, let's use the chat anyway. So type your questions into the chat, and I will moderate them to make sure that they're answered in sequence. And after all the questions that have been asked have been answered, then people who are not IHPME faculty will leave the call, and Aniket will also leave the call, and the remaining faculty will stay behind, talk about the defense, talk about the proposal, and make recommendations to the committee as to how to proceed. So if that's clear to everybody, I'm just going to introduce now. So we have Dr. Aniket Bankar, who is going to talk to us about the association of frailty with clinical outcomes in myeloproliferative neoplasms. This will be a population-based study from Ontario, Canada. If you want to go ahead, that'd be great. Thanks.
Thank you, everyone, for joining in today. I hope everyone is keeping cool as we go into the summer. This is one of the last presentations in the ClinEpi rounds. My name is Aniket Bankar. I'm a leukemia fellow at Princess Margaret Cancer Centre, and I will be presenting my thesis proposal, which is titled Association of Frailty with Clinical Outcomes in Myeloproliferative Neoplasms, a population-based study from Ontario, Canada. My supervisor is Dr. Shabir Ali Bhai, and committee members are Dr. Vikas Gupta, Dr. Matthew Cheng, and Dr. Ning Liu. The outline of today's talk is to understand the concept of frailty and rationale why we are studying its implications in myeloproliferative neoplasms, and then go on to present the study plan and discuss potential limitations and biases. When I moved to Canada about 3 years ago, I noticed a significant change in the epidemiology of leukemia patients that I was seeing. So back home in India, I was used to seeing patients who were usually at presentation 60 years of age. But however, when I started seeing patients here, they were 70, 75, 85, and all getting kind of high dose treatments aiming towards curative intent. And this change has not gone unnoticed. If you see this excellent study published in Nature in 2019, we have seen that the percentage of patients or the incidence of leukemia in aging patients has increased by about 80% as compared to 20% in all cancers. Perhaps there is a biological explanation why we are seeing increasing incidence of leukemia in elderly population. However, what it brings us to is the challenges of determining their physical fitness when we are deciding their prognosis, their treatment decisions, whether they will have more treatment toxicities, and their goals of care. And this has, and the rate of aging that we normally see, because not all people who are of the same chronological age, they age similarly, because during aging, there is a decline in the physiological reserve because of decline in the multi-organ system functioning. And this rate of aging is highly variable. So if you see in this cartoon, person A at the top has had a decline in the physiological reserve, which is not as rapid as someone as person B, who has become frail over the course of 10 years. And the implications, the health implications of these are that patients who are frail have been consistently shown to have increased hospitalization, health resource use, increased falls and disabilities. And when you consider patients with malignancies, these patients have increased treatment resistance and treatment toxicities. So the crux of the matter is that determining frailty or the vulnerability to poor outcomes is more important than the age as a chronological age as the parameter itself. This has been taken into consideration by ASCO, which is American Society of Clinical Oncology as well, who recommend geriatric assessment in all people above 65 years of age, because they say that it identifies vulnerabilities not routinely captured in oncology assessments, and this evidence quality is high. However, the studies on prevalence and impact of frailty in leukemia continue to be limited. Those of you who don't know what myeloproliferative neoplasms are, these are discrete groups of leukemia, which are essentially chronic hematological malignancies. Their natural history could range anywhere from 3 to 20 years, depending on which type of MPN we are talking about. There are three classical myeloproliferative neoplasms. One is polycythemia vera, second is essential thrombocythemia, and third is primary myelofibrosis. And there are two most important clinical issues in these patients, which is reduced survival, which again, as I said, depends on what their disease biology is. And these patients have very high incidence of thrombotic events with a hazard ratio of 2 to 3. And all these thrombotic events mostly occur within the first 1 to 2 years of their diagnosis. Besides this, we have also shown that patients with MPN, although they are perceived as quiescent malignancies because they do not require acute treatments as in other cancers, they have high health resource utilization. And this was a study that we did, again, from the ICS database, which showed that older patients and patients with thrombosis are indeed the high cost users when it comes to MPN versus matched controls. Another important piece is that currently the risk stratifications that we use in MPN patients for predicting survival and thrombosis, which as I said are most important clinical issues, all these scoring systems use chronological age as one of the variable. None of them have accounted for this heterogeneity in aging, which is essentially frailty. And this is what the aim of this study is, to see if including frailty as the variable turns out to be significantly associated with these poor outcomes. So as I said, the aims of this study are to measure the association of frailty with all-cause mortality in patients with myeloproliferative neoplasms. The second aim is to measure the association of frailty with thrombotic events in patients with myeloproliferative neoplasms. This is the study overview. So the population would be all adult patients diagnosed with myeloproliferative neoplasms in Ontario between 2004 to 2016. The exposure is going to be frailty status. We will determine this frailty status using Mac-Isaacs frailty index, which I will talk about later, and Johns Hopkins adjusted clinical group frailty indicator. And the main outcomes, the primary outcome, as I said, going to be all-cause mortality, and the secondary outcome is cumulative incidence of thrombosis. This is the timeline of where the study inclusions and the observation period. So as I said, 2004 till 2016, all patients with MPN, all adult patients with MPN. We will have a 2-year look back period for documenting their frailty status after before their index event. The covariates would include disease characteristics such as age, sex, complete blood count, prior history of thrombosis, because that can determine our outcome of cumulative incidence of thrombosis, use of anticoagulant or cytoreductive agents, and there will be health services factors such as time period of diagnosis and Canadian marginalization index. From index date, there will be observation period till December 31, 2019. And outcomes, as I said, will be death from any cause or cumulative incidence of thrombosis. Coming to patients, we will be linking the data from Ontario Cancer Registry with ICES. Having said that, we have already had this linkage done for our prior project. This was a deterministic record linkage. We do not load the linkage error. However, there have been studies in the pediatric population where the sensitivity of picking up leukemia cases has been documented to be around 80%. Study population will be all MPN patients diagnosed from 2004 to 2016. Inclusion criteria would include age 18 plus years, We will include them using the ICD oncology topography code of C42 and the morphology codes as mentioned here. Patients would be excluded if they had invalid IKN, they were non-Ontario residents, or they had death prior to the index event. And specifically patients with chronic myeloid leukemia, because sometimes there can be a misclassification of these patients into MPN. So the CML patients are a distinct group and they're treated differently, so they would be specifically excluded. Coming to our exposure, which is frailty status, this will be measured using Rockwood's cumulative deficit approach. So someone who is not used to this frailty measurement, what Rockwood's concept of frailty says is that if you consider, say, about different health dimensions. So for example, aging, there are comorbidities, there is nutrition, social isolation, and physical function of an individual, and create a score, say, out of 30 variables. Just for an example, here I'm showing 40 variables, which represent all these 5 dimensions of health. And if you start counting how many deficits that person has, so for example, if the person is underweight or overweight, that comes into problems with nutrition, or if the person has poor physical function in terms of difficulties and activities of daily living, he scores 1 point for deficit in physical function. And what this approach says is that you have to start counting these deficits and multiply and divide this deficit by the number of variables that you've included in the scale. So for example, in this I've shown 40 deficits, and if, for example, this is an individual who has got 6 deficits out of these 40 variables, his frailty index would be 0.15. It has been shown that higher the index, worse the clinical outcomes. There are different concepts of measuring frailty. However, for administrative database purposes, Rockwood's this cumulative deficit approach is I mean, there is a construct validity for using it with the administrative databases. So using this approach, we will be using a frailty index called as MAC-ISACS frailty index, which was used in the ICES administrative databases and published in 2019. This has about 30 variables encompassing different dimensions of health. So the total score would be 30. So the frailty index would be calculated as number of deficits upon 30 within 2 years prior to the index date. This score has been validated for use with administrative data and for patients undergoing elective surgery in the province of Ontario for the outcome of mortality. We will also be using another measure to document the frailty status, which will be using Johns Hopkins adjusted clinical groups frailty defining diagnosis. This has also been validated for use with administrative health databases. It has 10 domains of health, as mentioned here, and the frailty is defined as presence of more than one diagnosis. So this exposure variable will be binary, either presence or absence of frailty. Our control would be, because we'll be using the MAC-ISACS frailty index as a continuous scale, so patients with lower frailty index would act as controls. But as I will be mentioning in analysis, we will also be categorizing the frailty index into a 4-level categorical variable. So a person with a frailty index of less than 0.1 would be defined as fit. And then as the frailty index increases, they would be defined as vulnerable, frail, and most frail. This is based on the work from Rockwood and group from Dalhousie University. We would also categorize this as binary variable. So patients with frailty index of less than 0.1 would be categorized as fit and more than 0.21 as frail. And as I said, the Johns Hopkins frailty index would categorize patients anyways as fit and or frail. Our primary outcome would be all-cause mortality. We will use Ontario Registrar General Database for documenting this outcome. If the patients were alive, then the patients would be censored at the last date of study follow-up or date of loss of OHIP eligibility. Our secondary outcome is cumulative incidence of thrombosis. We would define arterial and venous thrombosis according to ICD-10 CA codes. We will use the CHDAD, NACRS, and OHIP databases to look for thrombotic events. Importantly, these codes have been validated in ICS with a sensitivity of more than 75% and a specificity of more than 90%. We would be only using the first thrombotic event because we don't want to look at the recurrent, because that will introduce more complexity in the analysis. If the patients did not experience thrombosis, we would be censoring them at the last date of study period, which is December 31, 2019, or loss of OHIP eligibility. Occurrence of death during the follow-up period would be considered as a competing risk for occurrence of thrombosis. Just a slide on how we will be defining the thrombosis. So site of thrombosis would be defined as venous. These are all user-defined categories which have been picked up using the ICD-10 CA codes. So venous, we will be categorizing them into venous and arterial thrombosis depending upon where is the site of thrombosis. These are the covariates that we will be using in our model, and the data sources for them have been mentioned in front of them. So we'll be using age at index event as one of the disease-related factors, sex of the individual, complete blood count. So for complete blood counts, we'll be using the Ontario Laboratory Information System. We will consider the highest value within 3 months prior to the index event for the complete blood count, which is hemoglobin, white cell count, and platelets. We will document prior history of thrombosis because patients would have increased mortality and increased thrombosis if they have had a prior history of thrombosis. So it will be important to include that in the models. We'll be using information on anticoagulation drug as a time-varying covariate, which will come from ODB and NDFP databases. And we will also use cytoreductive drugs, which are hydroxyurea and ruxolitinib. These are the only 2 drugs which are most commonly used in chronic patients with myeloproliferative neoplasms for controlling their blood counts and can essentially impact the incidence of thrombosis. So they will be used as time-varying covariate as well. We will include health services related factors, which is time period of diagnosis, because in our previous study, we have seen that patients were diagnosed more frequently after year 2010. So about 70% of patients were diagnosed after 2010 in our previous study. So obviously with the time period of diagnosis, the pattern of treatment and the care changes. So we will be including time period of diagnosis as one of the variable. And we will also include Ontario Marginalization Index, which looks at which categorizes patients into 5 categories depending on how much marginalized they are. This Ontario Marginalization Index is it consists of 4 variables, which is residential instability, material deprivation, ethnic concentration, and dependency. And as I said, score ranges from 1 to 5. We will exclude, while coming to the analysis, so for data cleaning and handling of missing data, we will exclude cases or single variables with highly improbable data. It is possible that while calculating frailty index, we might have missing variables, and the way around is to essentially calculate frailty index using the available number of denominators. So for example, if you have availability on say 25 variables, then we will use the denominator as 25 to calculate the frailty index. This has been shown that even if we include about 20 variables in the frailty index, it still holds true in essentially predicting the poor outcomes. We will analyze the variables for missing completely at random, missing at random, and missing not at random. We will use multiple imputation techniques for imputing missing data for variables using the mice approach. Imputation for observations, which are M and AR, will not be done. Only complete case analysis will be done in such cases. Analysis of our primary outcome, which is all-cause mortality, will be using the Cox proportional hazard analysis. We will consider including the predictor in the multivariable model if the univariate analysis shows a p-value of 0.2 or 0.25 or less. We'll use the Kaplan-Meier method to derive the survival probability and compare them using the log-rank test and the Cox proportion hazard model for multivariable analysis to report hazard ratios. A two-sided p-value of less than 0.05 would be considered statistically significant. Our secondary outcome is cumulative incidence of thrombosis. As I said before, this would be a competing risk analysis to account for death before a thrombosis event. To evaluate the differences between exposure groups in the presence of CR, a fine-grained test would be used, and we'll be reporting the association with the exposure using the subdistribution hazard ratio. We would be testing the model assumptions, the Schoenfeld residuals for proportional hazard assumption. If they are violated, we will use a stratification or introduce a predicted time interaction. We will test for the log linearity using the Martingale residuals, outliers using the deviance residuals, and model fit using the Cox-Snell residuals. We will be carrying out some additional analysis. We will use Mac-Isaac's frailty index as a categorical variable in the prediction models, as I mentioned before. We will also test the agreement between two measures of frailty, which is the Mac-Isaac's frailty index when used as categorical, and the John Hopkins frailty index, which is anyways a categorical variable using Cohen's kappa statistic. We will also do a sensitivity analysis because we know that the provincial drug coverage policy restricts access to anticoagulation drugs to patients more than 65 years of age. So we will use a sensitivity analysis to see if there is any change in the incidence of thrombosis in our models when we look at the outcome in patients aged less than 65 years versus more than 65 years of age. Coming to sample size and power calculation, based on our prior published work, we expect a sample size of approximately 8,000 subjects. The power of the study to demonstrate a hazard ratio of 1.5 using a non-binary variable frailty index would be over 99%, as was calculated using the method of Haish and Labori. Coming to potential biases that we could face in our study. So the selection bias is unlikely because we will be including all patients with diagnosis of MPN from Ontario Cancer Registry. However, as I said before, that it is likely that patients were not picked up early enough because the diagnosis of MPN and these cancers became, the physicians became more aware only after 2006 or 7, when actually the molecular testing for this disease came into existence. Exposure bias, yes, it is possible. There is a misclassification with our frailty indices, and that's why we will be performing sensitivity analysis using different cutoffs and another frailty scale to assess the relationship between exposure and the outcomes. Detection bias is unlikely as our outcomes are discrete. However, it is possible that frail patients encounter the health system more frequently and therefore are likely to have thrombosis as outcome picked up more frequently. Attrition bias is possible, and therefore we will be using a survival analysis with censoring of the data at the last follow-up. There is possibility of reporting bias, especially during analysis. We can do a blinding of the data analysis to the exposure groups to avoid this reporting bias. Confounding, as I have mentioned before, and therefore we will be using the covariates as mentioned before and the regression analysis. There are potential limitations, which is inability to account for the genetic disease features such as molecular characteristics, which are not found in the population-based databases. Coming to feasibility and funding, the study is feasible because prospective follow-up is not required. We've already had a linkage with Ontario Cancer Registry, and the approval to access data has already been obtained because of our prior study. The members of the study team have extensive experience, and the funding has been kindly obtained from Elizabeth and Tony Comper MPN program through Princess Margaret Cancer Foundation, Toronto. The significance of this study is that frailty is potentially preventable and could help improve clinical outcomes in patients with myeloproliferative neoplasms. Measures to prevent frailty and its complications could also reduce the health resource use in these patients. Thank you everyone for patiently listening. I'm happy to take questions.
Hey, thanks very much. So I'm going to open up the chat to questions from the audience, and I think that's the way we'll do this. Unless you prefer to ask your question directly yourself, in which case we'll have to everyone's mics turned on. I'll read out the question and we'll go that way.
Okay, I have a question from Dr. Fowler. He says, can we review all the variables that we plan to include in the model? Let me go back. Here. So age at index event, that's known to have an impact on obviously mortality in these patients, and has been included in all the prognostic scoring systems in these diseases so far. Sex as a biological variable we will be including. Complete blood count we will also be including, because it is known that patients who have higher hemoglobin and higher platelet count could have higher incidence of thrombosis. Prior history of thrombosis, as is known, that can have increased incidence of thrombosis, recurrent thrombosis later on. And anticoagulation drugs and cytoreductive drugs, as I said, can vary the risk of having thrombosis later on. And the health services factors, as I said, the time period of diagnosis and the Ontario Marginalization Index. Dr. Fowler is asking about, does it capture the surgery and other chemo drugs and episodes of critical illness? So these patients, Dr. Fowler, are, as I said, are chronic hematological malignancies, and most of them do not require upfront chemotherapy. So for example, most of them are on active surveillance. And so say, for example, a patient gets diagnosed with polycythemia vera, all that he requires is thromboprophylaxis. If he has high risk of thrombosis, they don't require any surgery or any upfront chemotherapy for their treatment, unless they transform to a blastic phase, which is quite rare to happen. Like that's essentially at the end of their natural history.
I see you're managing the questions by yourself, Aniket, so we'll keep doing it like that, if you're fine with that.
Okay. Can people talk because it's okay? Yeah, I think Dr. Fowler, yeah, we should. Yeah, we will look into it. Like if we need to account for any of these things. Yes.
So I think there are two similar questions. So so Rob Fowler asked, does this frailty index capture all the bad things we do to people, surgery, other chemo drugs, etc., so it's a critical illness? And then Bruno Ferrero had a similar question. He said that you could have the frailty index measured at baseline, but the frailty index might change over time as a result of treatment, hospital admissions, and so on. And
yes.
I think both people are asking about whether the frailty index will be stable over time, or whether you should update it with follow-up.
Yeah, so that's a very good question. We have thought about it, because the frailty, as we know, can be a dynamic phenomena. So for example, someone is fit today and he can become frail, say 1 year or 2 years down the line, and that can affect the outcome. But I think that's an important question in itself, and should be done with some other study if the dynamics of frailty change. I think at this point in time, in this study, we are looking at what is the association of frailty at baseline with the outcomes later on. But it is an interesting question, and could very well be answered with another study, whether frailty as a dynamic phenomena changes over time. I have a question for Dr. Marie Cran. Okay, so he asks about the clinical heterogeneity confound the results. Yes, it is true. Uh, so patients with PV and ET are quite similar in their clinical behavior, whereas patients with myelofibrosis behave differently. So we will be using the type of MPN as one of the variables in the models as well. And your question, why is this question important? The treatments for MPNs are pretty well tolerated, aren't they? This is not really true because we have seen that patients who get the JAK inhibitors, for example, the ruxolitinib, they failed their treatment quite early. Like for example, almost 50% of patients would fail the treatment in the real world scenario at the end of 2 years. And that could be because of toxicities or possibly the drug did not work. So, and partly we still continue to see the problem of thrombosis in these patients. So another interesting question is whether the treatment actually changes their frailty. For example, someone is frail at the beginning of their treatment and we treat them with ruxolitinib, whether it changes their frailty and they become fit. Because we know that it decreases the chronic inflammation and can essentially make patients fitter. So those are different questions in itself, whether we can change their frailty using treatment.
Okay, if there aren't any more questions typed in, that's George Thomas. I have a question. So you described a number of analyses, and so the main question, as far as I understand it, is whether frailty predicts mortality or thrombosis over and above these other baseline variables like age, sex, and the other variables you've listed here. Mm-hmm. Is that correct? So, I'm not trying to belittle that question, but it seems that it will. But is it a yes/no question? I mean, does frailty have an effect on mortality? Presumably, the answer is yes. Even before doing the study, you could probably say, it does. So, what refinement can you give apart from yes, it does, or no, it doesn't? Are you trying to quantify the extent of the effect, and how will you do that?
So I'm trying to see if frailty is a better predictor than the age itself, because if I'm going to show you some data. So this is a study that this is currently under peer review, where we looked at, we actually measured frailty using cumulative deficit index in all patients diagnosed with myelofibrosis at Princess Margaret Cancer Centre. And as expected, the frailty did predict a worse overall survival. However, when we did a multivariable analysis, we found that patients who are frail, patients who are older, say for example 65 years or older, they did not have a significant association with worse overall survival when we included frailty as one of the parameters. So someone who is 65 and older, we cannot change that variable, but someone who is frail, it is potentially preventable, and essentially we say we prevent frailty and prevent bad outcomes.
Okay. Murray had a follow-up question. I'm going to think about your response for a moment. He wrote, and you can probably see it, he said, it's not whether frailty changes, it's whether frail patients can benefit from treatment.
Yes, so that, I think the treatment outcomes are not very well captured in the ICS databases. The first thing is to essentially show that frailty does impact the outcomes. And the next is to essentially show that frailty patients with frailty may or may not benefit from treatment. But that's an important question, and that would require more finer data essentially.
So the slide we're looking at now, this is a multiple regression analysis with all those variables in the same model. Is that correct?
Yes, that's right.
Okay. And I guess again, going back to sort of my previous question. So if you get results something like this, again, how do you use that in practice?
So
because those hazard ratios are, we know the hazard is 3 times as high, but how does that translate into actual risk of the outcome? Is that something?
Currently, we don't do geriatric assessment or frailty assessment in patients with myeloproliferative neoplasms as baseline, essentially. And so if we show that the frailty essentially is associated with poor outcomes, this would change clinical practice in terms of at least getting patients to a geriatric consultation to make sure that we document and we see if there are any vulnerabilities in them in terms of having poor outcomes. And this is more and more going to be required because we've seen that patients have really heterogeneous fitness levels when it comes to tolerating treatments or, for example, discussing prognosis essentially with them.
Thanks. There's a question from Lucine around the competing risk issue. Why do you select the sub-distribution hazard model over cause-specific hazard model?
Because essentially we wanted to account for death as a competing risk. So that's why we use the sub-distribution hazard model. We are not essentially looking at the etiological aspect of why the thrombosis occurs, but essentially measuring the association of frailty with thrombosis. I mean, the cause-specific hazard would be like to specifically look at the etiology of thrombosis.
There's a follow-up question from Rob Fowler. I think that frailty will be associated with outcomes. I think we need to work on ensuring that there's both strong independent association, looking at co-interventions, things that make people both more frail and maybe die, things that make people better, geriatrics consultation, rehab maybe, and changes over time for frailty. While these might be the subject of a second paper, second masters, in quotes, I think you get a lot of questions about this during eventual peer review, making sure you've accounted for all the potential factors.
Okay, so yeah, that's a great suggestion. We will try to incorporate this.
So I guess what kind of following up on my question, what I was trying to emphasize is that I think to make this useful, it'd be one result might be if you show the frailty index is predictive of mortality or predictive of thrombosis, people might start assessing frailty. But in terms of quantifying the effect on the risk of mortality and so on, I think you need to look at some absolute measures. What is the absolute increase in risk for someone, given all the other covariates when they go from being fit to pre-frail to frail, and that is probably where it's important to use the competing risks models, because when you look at absolute risk in a competing risk situation, then the competing risk models are more appropriate. It's not etiology, it's prediction and prognosis. So I think we're used to seeing these things. We think, yes, there's an association or there's not, but really there are different degrees of association. And I don't think people are going to be surprised that frail people have higher mortality, for example, than non-frail people, but saying how much benefit you get in prediction from measuring frailty would be, help you justify doing it. Just saying that the hazard ratio is 3, which sounds like a lot, but what does that mean in terms of absolute difference in risk for someone? I think that it's a bit more work, but I think translating it back to, absolute risk for different groups of people would be useful, because some people, presumably, if they're younger, and have low ECOG status and so on, hazard ratio 3 might still put them at a low absolute risk.
Yeah. Okay. Yeah, that's a good suggestion.
And I'm asking all the questions because it's easy. I'm going to type them in. But you're correct. So these categories of fit, pre-frail, frail have been defined by McIsaac for that scale?
So those are defined by Rockwood. Like the 4 categorical variable has been defined by Rockwood.
Okay.
And the 2 categorical variable has been defined by Hoover in one of his studies. So those are like standard cutoffs that are used.
Okay. And did you say you're also looking at the continuous variable?
Yeah, so that will be the primary analysis. So using the MAC-ISAX as the continuous variable will be the primary analysis.
Okay, good. I don't see any more questions. So we'll give it a minute. And then I think maybe we'll close the discussion and have close the open discussion, have a closed discussion. Going once. Okay, so if there are no more questions, I think we'll finish this part of the defense, and we'll ask Aniket and all non-faculty members to leave the call. And if you're a faculty member, stay on the call. And I think Shabir will probably get in touch with you afterwards, Aniket. Thanks for a great presentation and for answering the questions so well.
Thank you.